Good afternoon. My study for presentation today is awareness and use of COTS guidelines for ocular TB among ophthalmologists in Kerala. TB remains a major public health challenge in India, both pulmonary and extrapulmonary disease. TB uveitis is an important cause of infectious uveitis. Its different manifestation and clinical signs often lead to diagnostic uncertainty, delayed initiation of ATT, and variable treatment outcome. To address these challenges, COTS, the Collaborative Ocular Tuberculosis Study Group, developed a consensus-based guidelines aimed at standardizing diagnostics and therapeutic approaches. They also have an online open access digital tool. Both the guidelines and calculator provide recommendations on when to initiate ATT, considering both systemic and ocular findings into decision making. The aim of my study is to assess the awareness, understanding, and clinical application of COTS guidelines among ophthalmologists in Kerala and to identify perceived barriers to their implementation in clinical practice. Going to the materials and methods, it was a cross-sectional anonymous questionnaire-based survey conducted among ophthalmologists practicing in Kerala across various subspecialties and institutional settings. A structured online questionnaire was developed using Google Form. The questionnaire link was distributed electronically through professional ophthalmology groups and academic groups, and participation was voluntary. No identifying personal data were collected to ensure anonymity. Responses were collected over a period of 3 months. A total of 219 ophthalmologist responses were obtained. The Google Form platform provided automated response summaries in the forms of tables and charts. Data were further compiled in Microsoft Excel and analyzed using descriptive statistics. The results. A total of 219 ophthalmologists responded to the survey. Nearly all respondents reported managing uveitis patient in their routine practice. The majority were in the age group of 30 to 39 years. Most respondents were females, while 9.6 were males. With regard to ophthalmic experience, 41 had more than 10 years of experience. Subspecialty distribution showed that general ophthalmologists and retina specialists formed the largest group. In terms of practice setting, private eye hospital was most common, followed by academic institution. With regard to ocular TB, 52% reported rarely seeing presumed cases, 36% saw 1 to 3 cases per month, and 12% encountered more than 3 cases per month. The most commonly used investigations were MANDO and chest X-ray, followed by IGRA, sputum gene expert or AFB, and HRCT test. The vast majority reported never initiating ATT empirically. Always a collaboration with pulmonologist or infectious disease specialist was reported by about 87%. Now, to awareness of COTS, consensus guidelines was limited, with 57.5% were unaware. The awareness of COTS guidelines was higher among retina and uvea specialists compared to general ophthalmologists, although the difference did not reach statistical significance. Among those aware, the main source of learning were CMEs, peer discussions. Understanding of this criteria, among those aware, the understanding of COTS criteria was complete in 47%, partial in 40%, and absent in 13%. Among 93 aware respondents, 52% reported always using the guidelines. Awareness of COTS calculator was even lower. Only 34% had heard of it, of whom only 12% of total respondents actively used it. On a confidence scale of 1 to 5, most respondents reported a moderate confidence in using COTS calculator for treating TB uveitis. The most frequently reported barriers to using COTS guidelines were lack of time or resource for a complete workup and lack of awareness. Other barriers included institutional conflicts, concerns about ATT toxicity, and reluctance from infectious disease specialists. Going to the discussion, the diagnostic workup patterns were heterogeneous with heavy reliance on conventional tests like MANDO and chest X-ray, while diagnostics like interferon gamma release assay and high resolution chest CT were underutilized. Empirical initiation of ATT was infrequent among our respondents, suggested a cautious clinical decision making. Multidisciplinary collaboration with pulmonologists and ID specialists was high, but a guideline-based standardization remains incomplete. Few of the ophthalmologists also reported that a few pulmonologists refused ATT initiation when systemic TB was not demonstrable. Only less than half of the respondents were aware of the guidelines, and even fewer reported consistent application it in practice. Key barriers identified were lack of time, resource, and awareness. And the limitations are it had a limited sample size, therefore did not represent all ophthalmologists across different practice settings. It was self-reported, therefore there is a potential for recall and reporting bias, and it didn't evaluate the impact of guideline adherence on patient outcome. My conclusion are the awareness, understanding and adoption of COTS guidelines for managing tubercular uveitis are below optimal levels. The key barriers were lack of time, resource and awareness. The recommendations are, one is that a wider and targeted education initiative can be undertaken to improve awareness of COTS guidelines, especially among early career ophthalmologists and those in non-academic settings. Awareness can also be targeted to pulmonologists or infectious disease specialists to strengthen collaborative decision making. Also, as the COTS guidelines are complex to recall in routine practice, wider promotion of COTS calculator can greatly simplify decision making. Also, future studies can be done with a larger and more diverse study population to better capture practice variation. And also, studies need to evaluate whether increased awareness and use of COTS guidelines can improve diagnostic accuracy and better patient outcome. These are my references. Thank you.
Very good presentation, Shafeeja.
Thank you.
Not sure, I'm not also not very much aware of these guidelines. So, among those who initiated the treatment, were they, did they tell the patients to follow up for any toxicity, vision loss or things like that? Because we have to be concerned about ethambutol toxicity. Was that included in that
Actually,
protocol?
in my questionnaire, it wasn't included. We just had a COTS guidelines, whether they are aware or not, or how many are using it in. But in our institute, we usually call the person every monthly to check vision and color vision. Initially, also before starting ATT, do a fundus and a field examination, and every month the color vision and field vision testing.
So you have done a good study. So when you elaborate it further, you can make that recommendation also.
Okay.
Maybe you can modify add your name to the COTS.
Okay.
This thing to have that follow up for ethambutol awareness toxicity also. Are they aware so that they don't miss out?